Welcome to Group C presentation of ankle fracture dislocation and tourniquet uses in theatre. In our presentation consists of ankle fracture and dislocation including tallus fracture, calcaneum fracture, malleolus fracture, pilon fracture of distal tibia, ankle fracture in children and dislocation. And the other main topic is about tourniquet uses in theatre.
Tallus fracture. So mechanism of injury is when there is a motor vehicle accident, they might have an axial loading and subsequently can have talar neck drive into tibial margin. And usually the symptoms that might be presented to the hospital, patient might complain of pain or swelling of the foot and ankle. And if fracture displaced, they may have deformity, denting or splint of the skin. And in the severe cases, the skin may slough and being infected. So investigations of the tallus fracture, mainly the gold standard is we do X-ray in anterior posterior view, lateral or axial view also. So at the left side of you guys can see here in which it is a lateral view of the tallus fracture. And the other side, the talar fracture in oblique view and also at the frontal view. So management for tallus fracture is divided into two, either non-operative and operative. So for non-operative, usually we do emergent reduction and also short leg cast for 8 to 12 weeks and also non-weight bearing for first 6 weeks. For operative management, usually we do open reduction and internal fixation in which ORIF indicate in all displaced fracture. And aim for this management is for revascularization and also fracture healing. So moving to complication of the tallus fracture, patient might have osteonecrosis, post-traumatic arthritis and also varus malunion.
Calcaneus bone is the most commonly injured tarsal bone. In most cases, patients fall from height or onto their heels. As you can see by the red arrow, calcaneus bone is driven up against the talus and is split or crushed. 20% of these fractures are associated with injured spine, hip, and pelvis. Calcaneus fracture can be divided into extra-articular and intra-articular fractures. Patients with calcaneum fracture are presented with painful swollen and large bruise on the lateral heel. As you can see on the picture, the heel will look broad and squat. There will be also a thick and tender tissue and lack of the concave below the lateral malleolus. The subtalar joint cannot be moved, in which that cannot be inversed or reversed, but the ankle movement is still possible.
So investigation of calcaneum fracture, the gold standard is we do X-ray. As you guys can see here, the lateral view of the calcaneum fracture and also lateral view in which there is an intra-articular fracture. So the other modalities that we can use to see the calcaneum fracture is by using CT scan. As you guys can see here, there is a types of calcaneum fracture in which at the left side it is in the sagittal view. So for the contralateral side, it is in the axial view. Moving to management of calcaneum fracture is also divided into non-operative and operative. So under non-operative, usually we do cast immobilization with non-weight bearing for 6 weeks for calcaneum stress fracture. So the second one, we can do cast immobilization with non-weight bearing for 10 to 12 weeks, in which usually for small extra-articular fracture and also Sander type 1. So moving to operative management, usually we do close reduction with percutaneous pinning and also open reduction and internal fixation, in which the short form is ORIF. So complications of the calcaneum fracture is either patient might have wound complication, subtalar arthritis, malunion, and also compartment syndrome.
Malleoli fracture. Introduction. Fractures and dislocation of the ankle are common. Most are low-energy fractures of one or both malleoli, usually by twisting mechanism. Less common are the most severe fractures involving the tibia plafond, the pilon fractures, which are high-energy injuries, often caused by a fall from height. Mechanism of injury. Patient stumbles and fall. The precise fracture path is determined by the position of the foot, next, the direction of force at the moment of injury. The foot may be pronated, supinated, and the force upon tallus is towards adduction, abduction, or external rotation or combination. The most common mechanism of injury is adduction and lateral rotation of the ankle. Lateral malleolus sheared off at oblique angle, and for the medial side, strain may rupture the deltoid ligament or produce transverse avulsion fracture of the medial malleolus. Next mechanism of injury is sudden adduction of the ankle. In this case, the medial malleolus shears off, and for the lateral side, strain injury or fibular fracture might occur. Clinical features. Ankle fractures are seen more in sportsmen and sportwomen, those who catch their foot, twist and fall in day-to-day activities. Older group includes women with postmenopausal osteoporosis who trip and fall. History of a twisting injury, intense pain, and inability to stand on the leg suggests something more serious than a simple sprain. Ankle swollen and deformity may be obvious. The site of tenderness is important. If both the medial and lateral sides are tender, a double injury, bony or ligamentous, must be suspected.
The name for malleolar fracture classification is Dennis-Weber classification. It is based on the level of fibular fracture in relative to syndesmosis. There are three types in this classification. Type A, when a fibular fracture is below the syndesmosis and there's an oblique fracture of the medial malleolus, usually caused by forced supination and adduction of the foot. Type B, a fracture is at the syndesmosis, which is often associated with disruption of the anterior fibers of the tibiofibular ligament, and there is fracture of the posterior and or medial malleolus, or any disruption of the medial ligament caused by forced supination and external rotation. In type C, fibular fracture is above the syndesmosis. The tibiofibular ligament must be torn. The ligament avulses a small piece of the tibia. There must be a disruption on the medial side of the joint, either a medial malleolar fracture or rupture of the deltoid ligament. This is the picture showing the Dennis-Weber classification. How we investigate the malleolar fracture. So basically, the best imaging tools will be the X-rays with the anteroposterior view, lateral view, or oblique mortis view. From the X-rays, it is possible to reconstruct the mechanism of injury. In some cases, further X-ray may be needed to exclude a proximal fibular fracture up as high as knee. CT scan occasionally done because it is useful to confirm fractures which is not definitively seen on the X-ray. It also can evaluate reduction of syndesmosis. For the MRI, it can be used to identify associated ligament injuries in malleolar fractures. So this is the anteroposterior view of X-rays for the ankle based on Dennis-Weber classification. In the first picture, this is the type A Weber classification. There is presence of fibular fracture below the syndesmosis, and there is presence of oblique fracture for the medial malleolus. Type B picture showing the fibular fracture is at the syndesmosis,
possible disruption of tibiofibular ligament, and also medial malleolus fracture. So the type C, the fibular fracture is above the syndesmosis. So this is the lateral view of X-ray for the ankle. The first picture showing the type B Weber classification. We can see the clearer image for the fibular fractures and also medial malleolus fractures. The second picture showing type C Weber classification is presence of fibular fractures, posterior inferior tibiofibular ligament disruption, and also posterior malleolus fracture. So this picture showing the antero-posterior view of X-rays for the ankle. So there is minimal displaced spiral fracture of fibula and also transverse fracture of the medial malleolus, which is laterally displaced. Because there is difficulty in obtaining the anatomic reduction, the CT scan was performed. So when the CT scan was performed, there's presence of bone fragment in the syndesmosis, which prevent the reduction, and also there's presence of medial malleolus fracture.
For the management of the malleolus fracture, for the general treatment, first we need to reduce the swelling, as the swelling is usually rapid and severe, particularly in high energy injuries. So we can reduce the swelling by elevate the legs and can be speed up by using a foot pump or cold compression. The foot pump can also reduce the risk of deep vein thrombosis. For the reducing of the swelling, it may need to wait for a few days. And then secondly, like others intra-articular injuries, ankle fracture must be accurately reduced and help to prevent the mechanical dysfunction. So different types of fracture affect the way of reductions. For undisplaced fracture, the first step is to decide whether the injury is stable or unstable. Generally, the reduction management is based on Dennis-Weber classification. For type A, these fractures are stable and will need minimal splintage with a firm bandage and also plaster slab applied mainly for comfort until the fracture heals. For type B, these are potentially unstable only if the tibiofibular ligament is torn or there is significant medial side injury. By using X-ray, we can see if the syndesmosis or mortise is intact. If it is intact, then a below-knee cast can be applied on ankle with neutral position. Then, check X-ray is taken at 2 weeks later to confirm whether the fracture remains undisplaced. An overboot is fit and the patient is taught to walk correctly as soon as possible. The cast usually can be removed after 6 to 8 weeks and physiotherapy needed to be done to regain the ankle and also foot movement. For type C, as these fractures are deceptively innocent looking, but they are often accompanied with disruption of medial joint structure as well as tibiofibular syndesmosis and also interosseous membrane. So for this kind of fracture, it's better fixed from the outset. For displaced fracture, reduction of this joint disruption is prioritized to all further treatment. For type A, medial malleolar fracture is nearly vertical and after close reduction, it often remains unstable. So internal fixation of the malleolar fragment with 1 or 2 screws directed almost parallel to the ankle joint is recommended. Those fragments are removed. The lateral malleolar fracture, unless it is already perfectly reduced and stable, should be fixed with a plate and screw or tension band wiring. Post-operatively, a working cast or removable splintage boot is applied for 6 weeks. The advantage of using removable splintage is that early physiotherapy can be done. So for type B, the most common fracture type is spiral fracture of the fibula and also oblique fracture of the medial malleolus. The causal mechanism is external rotation of the ankle when the foot is caught in a supinated position. Therefore, close reduction needs traction to disimpact the fracture and internal rotation of the foot is done. If close reduction succeeds, a cast is applied, but if failed or late redisplacement is done, call for operative treatment. Besides, This type of fracture can be caused by abduction, and often the lateral aspect of the fibula is comminuted and the fracture line is more horizontal. Therefore, to get accurate reduction, internal fixation is preferred. For type C fracture, the fibular structure is well above the syndesmosis and frequently associated with medial and posterior malleolar fragments. Almost all type C is unstable and will need an open reduction and internal fixation. The first thing is to reduce fibula and restore its length and alignment. Then, stabilize with plate and screws. If presence of medial fracture, this also is fixed. Then check for syndesmosis by using a hook to pull fibula laterally. If the joint is open out, means that the ligament is torn. Therefore, stabilize with transverse screw across the fibula into tibia. After open reduction and fixation, below knee cast or removable boot is applied.
Open wound need to be stabilized by internal fixation, even presence of open wound, provided the soft tissue are not too severely damaged and the wound is not contaminated. Check for extension of the damage to the soft tissue and also other structures, particularly neurovascular and also tendinous injuries. If internal fixation is inappropriate, external fixation can be used as temporary standing option. For complication of the malleolus fracture, it can be divided into early and also late complication. For early complication, it can present with vascular injury, so ankle should be reduced immediately and held in a splint until definite treatment is initiated. It also can cause wound infection and also breakdown, especially for patients with diabetes. For late complication, incomplete reduction is common and can sometimes be prevented by corrective osteotomy. It also can cause non-union and can be prevented by operative reduction and screw fixation. For joint stiffness, swelling and stiffness of the ankle are usually the result of the soft tissue injury. So for this joint stiffness, physiotherapy is very useful. Complex regional pain syndrome, where patient complains of pain in the foot and maybe have swelling and also diffuse tenderness. Lastly, it also can cause osteoarthritis. For the prognosis, it is dependent upon anatomic reduction.
Unlike the twisting injuries that cause the common ankle fracture, pilon fractures occur when a large force drives the talus against the tibia. Imagine a pestle being struck on the mortar, where the pestle is the talus bone and the mortar is the tibial platform. Due to the high force, there is usually a considerable damage to the articular cartilage, and the subchondral bone being broken into several pieces. In a very severe case, the comminution can extend even until the shaft of the tibia. Patients with pilon fracture are presented with ankle pain, swelling, inability to bear weight, and deformity. During physical examination, look for swelling, fracture blisters, any abrasions, open wound, and also any associated musculoskeletal injuries. Examine the range of motion and the neuromuscular status of the patient. For investigations, do an X-ray to look for the comminuted fracture of the distal end of tibia extending to the ankle joint. The recommended views are AP lateral mortis, and in severe cases, full length of tibia and fibula for fracture extension. Do a CT scan with 3D reconstruction to look at the tibial fragments for more detailed evaluation to delineate the articular involvement and surgical planning. After imaging have been done, patient with pilon fracture can be classified into type 1, 2, and 3. Type 1 is undisplaced fracture, type 2 is a minimally displaced fracture, and type 3 is markedly displaced fracture. As you can see in the picture D, this is a 3D CT reconstruction, where you can see the 5 major tibial fragments for more detailed evaluation of the fragments.
For the management of the pilon fracture, we can divide it into the conservative surgery and the post-operative. For the conservative, we can give the pain relief and the antibiotic prophylaxis. Usually, we giving it to the open or internal for open and internal fixation. We also can do the elevation. This is help to control the soft tissue swelling and the spleen for the immobilization. And then for the surgical, we can do the definitive surgery was there are some type of definitive surgery, which is we can do the open reduction, internal fixation, external fixation, limited internal fixation with the external fixation, and the last one is the percutaneous pinning. There are some reason that indication to do the surgery, which is consists of when the patient have the open fracture, displaced fracture, vascular compromise, and the last one is the compartment syndrome. And then after they finish doing the surgery, they have to do the elevation, post operation physiotherapy, and the partial weight bearing after the 6 weeks. For the complication, if the patient have the ipsilateral injury, 30% of them will develop some of these complication, while if there is present of bilateral injury, 5 to 10% will develop this complication, which is the compartment syndrome, compression of the vertebral column, especially at the lumbar one, and then contralateral of the calcaneus, tibia, plateau, pelvis, and acebulum, which is have the vertical shear injury, and then the last one is the vascular injury, and then they also have the secondary risk factor of develop the osteoarthritis due to the cartilage injury. So next is ankle fracture in the children. The physical injury are quite common in the children, and 1/3 of the cases occur around the ankle. For the mechanism of the injury, when the foot is fixed into the ground or trapped in the narrow space, the leg will twist to the one or to the other side. So this causing the tibia fasces to pull apart, and this is called this patient will have the Sutton Harris type 1 or 2 injury. And then for the clinical feature, the children can present with the pain, swelling, and bruising around the ankle. And then there is a presence of the acute tenderness during the physical examination. For the investigation, we can do the X-ray, but for the undisplaced facial fracture, we can easily miss it out. So we need to repeat the X-ray in the 1 week if there is no hint of the facial widening. For the CT scan, usually it used for the type 3 injury. As you can see from the picture, the C is the type 1, and type 2 Sutton Harris classification, which is the transverse fracture. And then for the X-ray, as you can see for the picture A, shown the type 2 injury, and the C showing the type 3 injury. For the management, it divided into the Sutton Harris 1 and 2, and the Sutton Harris 3 and 4, which is for the Sutton Harris 1 and 2, the extra-articular. For the we can treat it conservatively. We can give the pain reliever and the antibiotic. For the if there is presence of the displacement, we can do the close reduction under the GA. And then the next one is the Sutton Harris 3 and 4 intra-articular. We can do the if there is presence of displacement, we can do the open reduction, internal fixation, and then with the interfragmentary screw was inserted to the parallel to the fasces for the 6 weeks in the below knee cast. For the complication, the patient can develop the malunion if the reduction is imperfect. Usually, they will have the valgus deformity, but they are present of treatment. If the patient is less than 10 years, they can be accommodated by the growth and remodeling. If the patient is more than 10 years, we can do the osteotomy. And then for the asymmetrical growth, usually the patient will have this complication if they have the type 3 and type 4 injury. And then the last one is the limb shortening.
In ankle dislocation, the ankle is more vulnerable to injury during jumping and running activities, so it's more to occur in children, adolescents, and young male, especially those who involve in the sports activity. And in postmenopausal women, they are also at increased risk for associated fracture. During plantar flexion, the talus become narrower, and if you realize, the foot is typically in supinated position. So, despite all the tarsal bones stacked upon each other, the ankle it remains vulnerable to inversion strain and subsequent injury to the lateral ligament. But during the dorsiflexion, the foot is typically in pronated position. So, the strain is imposed into the syndesmotic ligament, medial malleolus, and also medial deltoid ligament structure. The main concern in ankle dislocation is associated fracture, ligamentous injury, and also neurovascular injury. So, during ankle dislocation, there is a large amount of force needed to break the ankle joint, which has a greater stability. So that's why in ankle dislocation, there are also associated fractures that need to be sought out during clinical examination. The ligamentous injury in ankle dislocation is mainly occur for anterior talofibular ligament, and neurovascular injury can be checked by checking the skin changes, the nail changes, the capillary refilling time, and also any numbness in the foot. The figure on the right side shows how ligamentous injury can be associated with ankle dislocation. During inversion sprain, the stretch upon the anterior talofibular ligament will cause dislocation between talus and also the fibula, while the eversion sprain, the everted foot will stretch upon the medial ligament, which is the deltoid ligament, and it can cause injury to this ligament. So on your left side is one of the common type of ankle dislocation, which is the posterior ankle dislocation. So in this position, the force, it moves the foot backward and the talus move in posterior direction in related to the distal tibia and cause dislocation. When patient presented with ankle dislocation, there is edema, pain, and also deformity of the foot. Also, you can find a tenting of skin by the malleoli, which is the stretching of the skin overlying the malleoli, and also tenderness along the joint line, which correspond to the area of capsular or ligamentous disruption. On the left side is the imaging plain X-ray of the ankle at anterior view and lateral view. The dislocation is more prominent on the lateral view of the ankle, where you can see the talus bone is not in contact with the tibia and also the fibula above. For management of ankle dislocation, an immediate reduction of the ankle joint is needed if there is any obvious neurovascular compromise. For this type of the ankle reduction, you can watch on YouTube by yourself for better understanding. After the reduction of the ankle joint, the joint should be immobilized, such as by the use of the casting, and patient should be further managed by rehabilitation.
Last part is about tourniquet use in theatre. There are several types, which the first one, wide awake local anesthetic no tourniquet. It is slowly infiltrating large volumes of very dilute lidocaine and adrenaline. So as it names, there is no tourniquet effect, so it will not cause paralysis. And this will allow the surgeon to assess the effect of tendinolysis, tension of tendon transfer, rotation of fixed finger fracture throughout range of movement, and alignment and offset of small joint replacement. Next method is tourniquet cuff, which we usually see in this hospital. So it will use the pneumatic cuff at least as wide as diameter of the limb. The wide cuff will reduce pressure needed for the vascular occlusion. This method must be applied with protective layer to the skin prior to the tourniquet replacement, like we put a layer of wool bandage beneath the tourniquet. So should avoid tight rubber bandage as it cannot control pressure beneath the bandage and it can risk damage underlying the nerve and muscle. During the skin preparation, make sure sterilizing fluid not leak beneath the cuff as it can cause chemical burn and it can be prevented with isolate the tourniquet with plastic. The next method is exsanguination. It is applied by elevation of the lower limb at 60 degrees for 30 seconds as it can reduce blood volume by 45%. We will use rubber tubular exsanguinator prior to the skin preparation. If minimum tourniquet time to be kept, we can use sterile X-mark or gauze bandage and wrap distal to proximal. This method indicated for truly bloodless field is not essential and also surgery for tumor or infection. The forceful exsanguination might squeeze pathological tissue into proximal part of the limb. The last method is finger tourniquet, so it will useful in minor hand operation. So we will use the sterile rubber glove finger and the tip is cut and the margin is rolled back proximally. Avoid use of stretched rubber catheter as it can damage the underlying structure and always check that finger tourniquet has been removed at the end of the operation. So for tourniquet pressure for the upper limb, we will use systolic of 150 mm mercury while lower limb 80 to 100 mm mercury of systolic pressure. This pressure may increase for patients with hypertension, obese and very muscular patient. However, higher pressure is unnecessary as it can increase risk damage of the underlying structure. Tourniquet time is N ischemia time, so absolute maximum time is about 2.5 hours. But the safer time is 2 hours. Usually transient nerve-related symptoms occur with 3 hours tourniquet times, but full recover by 5th day. Example of transient nerve-related symptoms like numbness or burning sensation of the affected area. This time can be saved by ensure limb is shaved, prepared, draped, and marked before inflating the cuff. The time must be recorded and the surgeon should be informed of elapsed time at regular interval, particularly as 2-hour period. Locally, deflation is followed by hyperemic response that reduced by half in 5, 12, and 25 minutes, respectively after ischemic times of 1, 2, and 3 hours. This information was useful for surgeon as it can try to obtain hemostasis after tourniquet release. If prolonged tourniquet time is needed, warn the patient about transient nerve-related symptoms and obtain consent to use absolute maximum time of 3 hours. So there are several complications of tourniquet. The first one, nerve injury, and next it can cause skin burns from the leakage of the alcoholic antiseptic solution. And lastly, failure to diagnose peripheral vascular disease before surgery. This complication can be prevented by using the white cuff, seal the cuff against seeping fluid, and avoid excessive tourniquet pressure. So that's all from us. Thank you.